So, good morning, ladies and gentlemen, dear chairman, dear organizers. First of all, I would like to thank for the kind invitation to give a talk on biology and therapy of advanced systemic mastocytosis. So, actually, I'm expected to talk about mastocytosis, but at the end of my talk, you will, I hope that you will see that this is actually a very complex, clinically and genetically complex, multi-mutated and multilineage stem cell disease. So these are the common features of systemic mastocytosis. So the genetic basis of systemic mastocytosis is a KIT D816V mutation, which you can find in more than 90% of patients. So it causes dense mast cell infiltrates in the bone marrow and also visceral organs and the skin. And the good thing about systemic mastocytosis, almost unique in hematology, that the mast cells produce something which can be measured in the serum. So this is the tryptase, and you saw before the normal tryptase level is below 11. So in systemic mastocytosis, we many times have tryptase levels of 50 or higher, and in some patients with mast cell leukemia, even 1,000 or up to 4,000 microgram per liter. So these are important KIT D816V, the dense infiltrates of spindle-shaped mast cells, and the elevated serum tryptase. So then this is the clinical picture. You have mast cell infiltrates in the bone marrow and in visceral organs. You can measure the bone marrow mast cell infiltration. You can measure the serum tryptase. And caused by the mast cell infiltrations, you have organ infiltration or even organ dysfunction. So this is all very similar to chronic lymphocytic leukemia or to myeloma. It is all based just on the mast cell burden. And as I said before, you find the KIT D816V mutation in 80 to 90% of patients. What makes the story complicated is that particularly in the patients with advanced systemic mastocytosis, you can also find the KIT D816V mutation in other lineages. So it's a multi-lineage disease. And then you find also monocytosis, eosinophilia, you find dysplasia in the marrow, you may even have blasts going to acute myeloid leukemia. And this is something the pathologists have already realized decades ago, and therefore they described the bone marrow as, on one side, mast cell infiltrates, but on the other side, infiltration by monocytes, and with the definition of CMML in peripheral blood, with more than 1,000 monocytes, they say, okay, there's an associated myeloproliferative neoplasm, myelodysplastic myeloproliferative neoplasm, or myelodysplastic syndrome, and the most frequent one is actually CMML. And this is also the reason why we have meanwhile identified a lot of patients which are actually diagnosed as CMML, but which have in fact systemic mastocytosis with associated CMML. And the problem is that then you need, of course, in the individual patient, you have somehow to work out, is now this infiltration, this organ infiltration, organ dysfunction, more caused by the mast cells, or is it more caused by, for example, CMML? But in fact, it doesn't matter because it is all the same disease. So, and this is, I would say, pretty similar to CML. So we have an indolent systemic mastocytosis, and this is a disease where usually only the mast cells are affected by KIT D816V. And then you have several subtypes of advanced systemic mastocytosis, for example, with associated a hematologic neoplasm, as I just explained, or mast cell leukemia with associated hematologic neoplasm. And it can be aggressive systemic mastocytosis, and the definition of aggressiveness is the presence of C findings, again, like in CLL or in myeloma, that patients have, for example, an hemoglobin less than 10, platelets less than 100,000, an albumin less than 25, or ascites, portal hypertension. So this is the measure of organ dysfunction. And some patients may even progress to acute myeloid leukemia or blast phase. So you may then have systemic mastocytosis with associated acute myeloid leukemia, and it's the same story. We have in our registry meanwhile identified 25 patients with acute myeloid leukemia, and in most of these patients they were diagnosed and treated as acute myeloid leukemia, but in fact had always been systemic mastocytosis with acute myeloid leukemia. And because patients are positive for the KIT D816V mutation, this knowledge of the underlying genetic lesion is of course of utmost importance for targeted treatment. So this also survival curve published by the Teferi group in 2009. So this is the largest series that was ever reported. So you see that in indolent systemic mastocytosis, in red, survival is actually identical to the normal population in blue. You see in green and yellow systemic mastocytosis with associated hematologic neoplasm and aggressive systemic mastocytosis. But please do not miss the survival curve on the left, because this is the survival curve of mast cell leukemia with a median survival of probably in all the patients definitely less than 3 to 6 months. So what about midostaurin? You know, there was a phase 2 study which was published last year in the New England Journal of Medicine so we initially recruited 160 patients, but we had to adjudicate many of these patients because of misdiagnosis of aggressive systemic mastocytosis. So finally, 89 patients were included in this phase 2 trial. And of course, you would expect from a drug that it reduces, for example, mast cell infiltration, and it also reduces the serum tryptase. And you see in these waterfall plots very nice results of the drug. So we saw, in fact, a decrease of bone marrow mast cell infiltration in many of the patients in green, confirmed even in a second biopsy, and the same was seen for the serum tryptase, so significant reduction of the serum tryptase. So the whole story is very much the same like for ruxolitinib in myelofibrosis. So you have this improvement of symptoms, you have improvement of splenomegaly, and here you can see particularly the improvement of symptoms. So in gray, the symptoms at diagnosis, and then the reduction of symptoms on a drug in green. And there are only two symptoms which are actually worse during midostaurin, but this is related to the drug. So this is really a toxicity. It's nausea and vomiting. And I would say that probably 60 to 80% of patients really have nausea, and you have to treat this nausea. Otherwise, the patients cannot stay on the drug. And also, we saw spleen size reduction. So this was also documented by MRI-based volumetry, like in the COMFORT trials. And you see that there were 30 patients 30 out of 39 patients had a response, and in 10 of 39 of these patients, the response was even more than 35%. So, and this is then the response over time. A major response means a complete resolution of at least one C finding plus reduction of the serum tryptase by at least 50%. And you can see that overall about 60% of patients achieved a major response. And these are then the survival curves and of the trial. And we are actually particularly proud of the survival curve in blue, because this represents mast cell leukemia. Please remember the survival curve I showed you before with the survival of 3 months. So we could, in the trial, at least prolong the survival to a median survival of 9.4 months in patients with mast cell leukemia. But when we started the trial, and when we saw the clinical course of individual patients, we also realized that something fundamentally is wrong. So we saw responses on one side, but then progression in the hematologic parameters. So it was not a very clear picture. And when we saw all these data coming from MDS and the MPN groups on additional mutations in myelodysplastic syndrome and also in myelofibrosis. We just thought, come on, let's check our patients also for these additional mutations. And it was probably not entirely surprising that we also find the same type of additional mutations in systemic mastocytosis, like TET2, SRSF2, AS6L1, RUNX1, and in fact, 60% of patients with advanced systemic mastocytosis had more than 2 additional mutated genes, and I could really show you a lot of pictures, and it's all so much the same like in myelofibrosis. So the type of mutation plays a role, also the number of mutation plays a role, and in univariate and multivariate analysis, we could clearly work out that there were 3 very bad players. This is SRSF2, AS6L1, and RUNX1. We called it the so-called SRA gene panel. And here you can see the separation of the survival curves. So this is only advanced systemic mastocytosis, just based on the molecular profile of the patients if they are positive or negative for one of these mutations. So, and then we also looked into individual colonies. And what you would expect in such a colony, you would expect a colony with a KIT mutation, you would expect a colonies with TET2, and you would expect colonies with both mutations or even 3 mutations in such a patient who is multimutated. But to our great surprise, we did not find a single colony only positive for KIT. And this was the same in overall 10 patients we investigated, and this is a very clear sign that KIT D816V in this disease is actually not the initial pathogenetic event. So again, I mean, what I'm talking about is really a summary of what you have heard yesterday. So again, these additional mutations are sometimes causing the clonality of the disease, and then, but obviously KIT D816V is a very strong phenotype modifier driving the disease into the phenotype of systemic mastocytosis with sometimes 90% mast cell infiltration in the bone marrow. So this is now, of course, again, and this was really inspired by the work of Serge that was done in myelofibrosis. We looked into the response on midostaurin based on clinical and genetic profile of the individual patients. And so overall, we have treated, so these are only patients from our institution, 38 patients treated in the trial and in the compassionate use program. And we had molecular data for these patients. And on the right side, you just see the characteristics of these patients. So, for example, median bone marrow mast cell infiltration 50%, median serum tryptase level 246, 60% of patients had low hemoglobin, 60% had low platelets or low albumin, and of course many of these patients had all 3 parameters contemporaneously, and almost all the patients have also an enlarged spleen with a median spleen volume of about 900 milliliter. So, and we did a lot of univariate and multivariate analysis on all clinical details, whatever you can imagine, on age, prior therapies, whether it is mast cell leukemia or not, whether patients have an associated hematologic neoplasm or not, on bone marrow mast cell infiltration. And the only parameter who finally came out in multivariate analysis that this genetic profile is the best baseline parameter for predicting overall survival. Here you can see the separation in our 38 midostaurin treated patients just based on the genetic profile of the patients. And if you see the red curve for the 23 patients with a median overall survival of 27 months, you would think, okay, patients who are positive for SRA are obviously no good candidates for midostaurin. But this is not true, and here I can unfortunately only provide historical data because of the paucity of the disease. We have no data from randomized trials. But if we compare from diagnosis, the median survival in midostaurin-treated positive patients, which is actually then 40 months, it is still significantly superior to patients from this historical control who are SRS positive who were treated with conventional drugs like, for example, hydroxyurea or cladribine. So independently of the genetic profile, the drug is obviously doing a good job. And we also looked into the allele burden reduction. I mean, you know, we have done that in CML, we have done that in myelofibrosis. And I think this is really also the first time that we can clearly show that allele burden reduction, and we did that by a minimal p-value approach, at month 6 of more than 25% is, in multivariate analysis, the best on-treatment prognostic factor for overall survival. So we have, in fact, not only a genetic factor at diagnosis, but also an excellent genetic marker on treatment of the patients. So, but again, the story is even more complicated. So we saw patients with a very nice allele burden reduction with a response, but they progressed to AML, very surprisingly. So, and with the first patient, we really didn't know what is going on. But then, when we had all the molecular data, it became very clear that obviously also the additional mutations play an important role for that. And I can only show you that formally. So we saw then an increase of the allele burden of the additional mutations, and we even had blasts who were negative for KIT D816V. So this is now, again, work that was already also done previously in myelofibrosis, that the blast phase is actually not caused by the phenotype mutation, in this case by KIT D816V, but by the additional mutations. And even we found new mutations at diagnosis of acute myeloid leukemia, and actually exactly the same, which we also know are important for progression of myelodysplastic syndrome or myelofibrosis like NRAS or TP53. And also cytogenetic analysis is very important, again, like in MDS, like in myelofibrosis, so all really all the same. So you can see here 16 patients in which we had a cytogenetic analysis, and in blue are unfavorable karyotypes, and we just took it from MDS, so like complex karyotype or trisomy 8 or monosomies, and you see all patients with a complex with this type of unfavorable karyotype died rapidly. And this is what I just showed you translated into a survival curve. So in red, you see the patients with mastocytosis with a poor risk karyotype, such as monosomy or complex karyotype, with a median survival of only 3 to 6 months. And all these genetic data now really explain what is going on in these patients with mastocytosis and with advanced systemic mastocytosis. So, and this is actually my summary slide. And I just tried to explain the complexity of the disease by the various subtypes. So on one side, we have only KIT D816V, no other mutations, and these patients usually present as indolent systemic mastocytosis. But we also know some patients who may, but this is rare, who may progress then also to aggressive systemic mastocytosis or even mast cell leukemia. But then, really, the aggressiveness of the disease is really caused by these additional mutations. They cause this associated hematologic neoplasms. So we then find as sort of a multilineage involvement the KIT D816V mutation also in monocytes and eosinophils. We may have additional cytogenetic aberrations or even CHEK2 V16F. But in these patients, so the low-risk cytogenetic aberrations or CHEK2 V16F, so in these patients we probably have 2 diseases. We could not prove that in many patients, but it looks as if patients then really have 2 different diseases. But the worst are those with additional mutations or even a complex karyotype or monosomy, and these are then really the patients who present with this aggressive systemic mastocytosis and associated hematologic neoplasm. And the worst one really is mast cell leukemia with associated AML, because this means 50% of, let me say, mast cell blasts plus 50% of myeloblasts, and there is really no very effective treatment for these patients, in many cases not even allogeneic stem cell transplantation. So this is my last slide. So this is from our single institution, the current survival of mast cell leukemia. Just remember, we had 3 to 6 months in the trial, before the trial, we had 9 months in the trial, and we have a series of 28 patients with mast cell leukemia, and their current median survival is 17 months. And this is all in all a combination of midostaurin, cladribine, intensive chemotherapy, and also allogeneic stem cell transplantation. Thank you very much for your attention.